Hello, everyone, and welcome to our part 2 webinar from the Maine Orthopaedic Review. I'm Bruce Gomberg. I'm happy to be here with some of my esteemed colleagues who will get an introduction shortly. I'm the director of the Maine Orthopaedic Review. I've held this post for about 15 years, and I'm happy to say I have been promoted to co-director this year. I have Emily Dodwell as my co-director this year, also on board with us tonight. And tonight we're going to talk a little bit about the best ways to strategize and organize for your Part 2 cases. Welcome, everybody. And I'd like to introduce Emily Dodwell from the Hospital for Special Surgery.
Good evening, everyone. I'm happy you're here, and we're looking forward to telling you all about Part 2 tips and tricks. I'm a pediatric orthopedic surgeon at Hospital for Special Surgery in New York, and thrilled to be co-director this year. I'd like to introduce our panelists. We have Mike O'Malley, sports surgeon at the Carillion Clinic in Virginia. He completed his orthopedic residency at the University of Connecticut with a subspecialty fellowship in sports medicine at the Mayo Clinic. And he now practices at the Carillion Clinic and serves as the team physician for the USA Hockey National Team Development Program. We also have Youssra Marjoua, hand surgeon at the National Hand Center in Baltimore. She completed her residency at the Harvard Combined Program and hand fellowship at the Curtis National Hand Center in Baltimore. She has an interest in public policy, has her master's in public policy from the Harvard Kennedy School of Government, and she is, in the last few years, just recently ABOS certified. So welcome, everyone. And we're going to move back to Bruce, talking about which cases are likely to be chosen for review and why.
Thanks, Emily. So, as you know, this is kind of a hair-raising time, and the board has a list of your cases, your diagnosis, your complications, and the question is, which cases are they going to pick? And the board is very good at this. They are very good at picking the cases they want to talk about. They are going to pick complications. They are going to pick cases that have complications because they want to know that you are thinking about how to manage things that go awry, how to manage things that are unexpected, and how to think about caring for the patient in a broader way than just your technical expertise. They want to know what you're thinking, and they want to know that you have a very coherent, cogent argument and thought process. They are going to pick controversial topics. For example, if you are doing arthroscopic debridements for knee arthritis, they are going to choose that. If you are performing metal on metal hip arthroplasty, they are going to choose that. They want to know how you think, how you make decisions, how you make treatment plans. And anything that's controversial, if I were talking to you a year ago, I would say limit controversy during your board collection period, or at least have the most well thought out, agreed upon treatment plan. And if you have anything that's controversial, make sure you document that you know it's controversial, that you may have talked with your partner, your professors, some senior colleagues about why you're doing it. They're going to choose any ethics violations. If you have a problem with an ethics issue, such as, for instance, one person advertised themselves as a board certified orthopedic surgeon before they even took the oral boards, or if you are operating on, say, family members, you need to know they're going to be highly sensitive to topics like this. If you are charging inappropriately, if you are charging, for example, for a neurolysis during a carpal tunnel release, they are going to be very tuned into things like that. If you have incorrect or repeatedly soft indications for surgery, they're going to be very aware of this, and they're going to choose those cases. You need to have clear surgical indications, and you need to be doing the correct operation for the diagnosis you're making. If you have repeated poor technique, technical problems, or outcomes, they are going to be tuned into that, and they're going to pick those cases. Not that we don't have complications. All surgeons have complications, and the only surgeons that don't are the ones that aren't operating. They want to know that your care is adequate, your care plan is exceptional, and that you are, when faced with obstacles, thinking clearly and doing the right thing for the patient. From my standpoint, I would be as conservative as possible during your board collection period, and I would make sure that anything that's not conservative or is something out of the ordinary is backed up with literature, is backed up with your professional consultation with senior surgeons, and that you have the best argument when you go into the oral boards. Not that I would say to be argumentative, I mean argument in the legal sense, that you have something to fall back on. So I hope I covered all of the cases that they will likely choose. And if you have any question, you can put them in the chat box. We'll be happy to address them.
All right, I think we're moving on to Dr. O'Malley now. He's going to talk about 5 things that he did right during the preparation period.
Hey guys, how are you? I hope everybody can hear me okay. Went a little casual tonight to loosen everybody up. So we're going to cover, basically 5 different points. Some of it Bruce touched on, but other ones that deviate from that a little bit. The first point that I would make, that I think that myself and anyone that took the oral board would say was that, seeking input early on during your preparation is absolutely key, because you really don't know what to expect from this exam. You don't know the nuts and bolts. You don't really understand much of anything until you really do a deep dive and you ask advice from those that have been there before, and not just by way of cases, but just the whole what the day is like itself, general discussion of what to expect, how to manage the stress that's involved with it, as it's a stressful day, and then the actual cases themselves. I think it's absolutely crucial to go over that with colleagues. And the way I approached this, and I think it was a good idea to do so, is I didn't just stay in my lane. I went and presented to colleagues from various different backgrounds and fields. And that way you get a good sense of what you might expect on test day, because you're not, if you're, say, a total joint surgeon, you may not just be presenting to other total joint surgeons. If you're say a foot and ankle, you may be presenting to a spine surgeon. You never know. And so you don't know exactly what questions they'll ask. Their job, honestly, is to try to kind of throw you off your game a bit. So you need to kind of expect the unexpected, if you will. And by preparing for that situation will help you significantly. So, I was a sports guy, but I presented to joints. I presented to trauma, foot and ankle, hand, all sorts of stuff. And I think I got really good feedback from all of my colleagues, that prepared me for the day. Not only do you get to present, different cases to different backgrounds, but you can also kind of get a sense of, and you can ask questions while you're preparing, like, okay, so, what image do you think I need here? What say, post-operative arthroscopic, view should I show at this stage or something like that? Because everything's going to need to flow your day. You only have about 10 minutes, to present each case. And so you need to make sure that it's very fluid. And so, which ties into the next point, by presenting, often, frequently, as much as you can to different people, you'll understand the flow of things, and you'll be able to set kind of like what the correct order of things should be before you even upload your stuff to the system. It's very important to do so, because you want to make sure that your case presentations go in a certain way, and they need to be very organized and concise. You're not going to have all the time in the world to present what you think needs to be presented. You need to present the pertinent info for them to understand each case very clearly, so that you can try to get through each one. You probably won't get through each one. Honestly, if I remember correctly, there was at least 2 or 3 where I didn't even get through. They just kept interrupting, like to just ask questions and stuff. And they weren't being like mean or anything, but they just had legitimate questions on, like imaging studies, and, one was a shoulder replacement on, the hardware, and so on and so forth. So you need to be able to deviate from your case a little bit, and then be able to bounce right back. So if they interrupt you, excuse me, and you're able to answer that question, and then you need to continue on with your presentation, you need to know exactly where to start up again, and then where to follow from there. And repetition really is key. And that's why I say, present to colleagues, make sure you understand the order of things. And once you're comfortable and you feel like, you have it down, then, think about starting to upload your material to the system, which then brings us to the next point, which is the pertinent information. So you don't have to load or present every single piece of information for every case. They are only going to see what you load on the system, right? So they don't need to see every single detail. They need to understand what's going on with that case. And so it's, I would say it would benefit you to go through each patient file and pick and choose what you think is going to be the best way to present it, meaning whether it's inpatient hospital notes, just outpatient hospital notes, the appropriate imaging. If it's a complicated case, for instance, that say had an infection where you need to present, laboratory studies and timelines of that, you need to be able to do that in a very stepwise fashion. And they don't need to see every single lab study. What you need to do is present it such that they understand the sequence, and that you were say trending labs and keeping a close eye on the patient and getting routine imaging and stuff like that. So, each case is a little bit different. So it's hard to come up with an exact example, but you'll know, like, for instance, I do a fair amount of arthroscopy. So, I'm not just loading arthroscopy sheets onto the system. I'm actually picking which pictures I want to present. If it's a meniscus repair, I show a healthy compartment with a meniscus tear. I show what I did. If you want, you can show that, the other compartments are healthy, but you don't need to show all 25 pictures of your arthroscopy, because you're just not going to get through it all. Similar thing, the MRI for say an ACL tear. You can say that, the lateral medial meniscus were intact, cartilage surfaces were intact. You could just show a couple, pics of each meniscus looking healthy, and then your ACL tear, and that's it. You don't have to go through, 30 images of the sagittal cut of a knee to show them that it's just the ACL that's torn. So that's just one example. You could pick and choose so that you can focus on like the pertinent information. I think pertinent negatives are important too, but pertinent positives, for sure, are what they want to see so that they can understand your decision making, and so that it shows that your decision making was sound, and that you can better defend your case, and you won't be struggling for time. It's really important to be very organized and concise. The next point Bruce touched on a little bit during his talk was the complications part. So everybody fears their complications. Everybody thinks that they're going to fail because of complications. It's a very common worry. I did same thing. But I'll tell you, they don't look at it that way. Every examiner has had complications in their career. It's just a fact. You operate long enough, you're going to have them. You don't hide from those complications. You embrace them. Those are the patients that you need to spend extra time on. And those are the patients that, in this particular instance, you need to spend some extra time preparing, for your case presentation. But you need to show them that you approached and you managed the complication in the effective manner. It's not going to be the fact that, just for an example, like say you did a total knee and it got infected. Well, if you have known infectious labs that are positive and you just give them an oral antibiotic and say follow up in 6 weeks, that's probably not going to be the best, plan of care. But if you show them, your workup and what you did and the sound decision making that you had, then you got nothing to worry about. And honestly, I will tell you that these are kind of the cases that you want to present. I realized this, honestly, I came to this conclusion about a week before my test, because, I kind of stopped being afraid of it because, it was managed okay. And the conversations that I've had with my colleagues about it were good conversations. And there were conversations about, not the fact that, maybe this was a mistake. It was a conversation regarding, okay, you realized it. You approached it the right way. You treated it the right way. You were compassionate. You showed empathy to your patient. You stayed with that patient, through it, and you handled it well. That's what they're looking for. So I just don't want you to go into that test day, thinking, oh man, there's a lot of complications on my pick list and stuff. Well, as Bruce alluded to, they love to pick those first and foremost, but it's more, the nitty gritty, just showing that, you managed it well. And then just to follow up, I probably should have tied this into the point number 3, but the last point was, things that I didn't upload, to the system, things that could have been left out. Well, I touched on that, a little bit before. Just be very kind of picky as to what you choose, because you just don't want to overload yourself. You don't want to make it, such that there's so much material that you're trying to force it out as you're presenting. You want to make sure that you include what you think is important. And it really depends on the case scenario, what that may be, so that when you present, it just flows and you're not talking super fast. You're not trying to like just shove it down their throat. You're actually just presenting it as if it was another case presentation during your residency, right? At say like trauma conference. And you show the pertinent x-rays or MRIs and you discuss what your decision-making was. And then you move on and then you show them how you treated it and outcomes. And so I would really be very meticulous in your approach to kind of deciding, what you think, needs to go on there. Because again, I will say it again, they only see what's on there. And that could be good or bad. And so just make sure that, whatever you upload isn't really too much, but it's not too little. It's just, that kind of like happy median where it's just enough. And, I think that'll be helpful for you, when it comes test day. So that's all I have. Happy to answer any questions, at the end or whenever. So
yeah, let's do a couple questions now. So we've got a couple questions here. So if anyone does have any additional questions, you can go into the question and answer segment if you go down to the 3 little dots on the bottom of the screen. So one question is, well, it's kind of a 2-part question. What do you do if you don't have any partners? Who can you seek advice from? And just a clarification on exactly how much input to get from your colleagues before you do the upload. colleagues or mentors?
Yeah, so if you don't have partners, if you're in solo practice, then like co-residents, co-fellows, possibly that you can contact so that you can present. You can do that virtually even now. I mean, I couldn't do it back when I was preparing. I can barely work virtual stuff now. It's pathetic, but you can do that now. And also, you know, don't be afraid if there's other colleagues in the community that you have become, you know, maybe somewhat close with, or you know, maybe have a working relationship with, you know, don't be afraid to call on them, you know, to do that. I did it. I presented to a couple of guys outside my group because I wanted more or less like an unbiased opinion, guys that didn't know me quite as well. And I thought that was helpful. And then for the second part, remind me what the second part was? Was it?
I think they're asking just how much to go over your cases with colleagues before deciding what parts to upload.
So in my humble opinion, you can't go over it enough. I think that was one of probably the most beneficial things I did was, you know, going over it as much as I could, because you just really don't realize how, you know, disorganized and how like you seem like when you're just doing it yourself, it seems like you got everything kind of together. And then when you start to present it, you realize, oh my God, this is taking forever to get through. Or, you know, one question from a colleague throws you completely off and then you can't remember where to kind of regroup. So I would say as much as you can present, because I'll tell you what, each time that I presented, I whittled down the necessary information a little bit more. So, you know, each case kind of started kind of big with a lot of stuff. And then I just kind of trimmed the fat as I went along. And by the end of it, you know, I felt way more comfortable presenting because I just didn't feel rushed. You know, I felt like I had a little bit of a system for each one. And so I would say as much as you can. If you can only present to two, you know, even one person, that's fine. But because you'll get a sense even with one person, you know, whether or not, you know, something is, you know, should be included or not be included. But, you know, I would just say do it as much as you can. I think it's helpful.
All right. Well, we're going to keep a few more questions for the end, some of the more general questions. So don't worry if we haven't gotten to them quite yet. So Dr. Marjoua is now going to tell us about the 5 things that she wishes she had done a little differently.
Thank you, Emily. Everybody can hear me okay? Yes, excellent. So I'm a bit more of a visual listener, if that's a thing. So I do have a PowerPoint so that I can sort of talk through what I'm thinking. And can everybody see my screen okay? Awesome. So my co-panelists might shake their head at me, and I hope not, but I would venture to say that the test is done before you show up. And what I mean by that is you've already collected the cases that you're going to collect. They're going to pick from those cases in a way that you can't control. By the time you actually show up to the test, everything that you can do to set yourself up for success is sort of out of your hands. So you can definitely work on sort of anticipated questions, answers, et cetera. But I would say, and Bruce, who's been doing this for a lot longer than all of us, could correct me if I'm wrong, I think for the most part, the goal of this is not to necessarily sort of set you up in a trap that tests how much you do or don't know about general hand surgery or joints or sports, et cetera. It's really to make sure that you're a safe surgeon who knows your own cases, has tight indications, and are able to execute them safely. So that, I think, is the way that I'm approaching this. And I would say I'll go through a lot of what was already discussed to some extent, and then just kind of delve into the details and logistics of how you actually are gonna set this up. So first of all, this is no longer virtual. And I'm pretty sure unless anything changes worldwide, which might, it is supposed to be in person. So you no longer have to worry about the virtual aspect of this. So we'll just very quickly go through what are the components, things I wish I would have done differently, and then where do you begin? So it's no longer virtual, and the degree of attention to detail, as Mike mentioned, organization, and I think your case summaries are equally important. The way that it works the day of is that you don't necessarily have an order that has to be followed. The examiner can basically go through your cases for all of them, and then decide, or for the one that they're assigned to, and then decide which one is most pertinent for them to talk about, which means that it has to be easy for them to be able to think through and look through your entire story that you're telling without going through every single note. This is what the case summary looks like. And you can see that it's basically similar to what Mike said, like the way that you would present in the morning in a very succinct, efficient way for what might be like a 3-part case, if it ends up being a case that has complications that requires take back to the OR, et cetera. This is how you're scored. So the scoring rubric is how a decision is made as to whether you will pass or not. And every single examiner is going to have to score you based on this scoring rubric. And you can see the elements that are included there. And then you can see that you can basically touch on
Youssra,
all of those. Yep.
I don't mean to interrupt you, but I don't think your slides are changing.
Oh, really?
Yeah, I think we just see your home screen there with the
How about now?
beautiful
Yeah. Can you see now?
coastline.
We're just
Nothing-
seeing the
not
view
yet.
outside your office window.
Yeah,
there.
yeah, that's your
Really? You're
window
just seeing
view.
you're just seeing my face.
No, we're seeing your face and we're seeing the view of the coastline outside your office.
Really? There's no coastline outside my office. That's a bummer. So you can't see my screen.
No, I think we see your screen, but it's just your home screen, like whatever that picture is on your home screen.
Weird. Okay, hold on. Let me try one more time because that would be, let me stop share. It says I'm sharing my screen and I'm looking at it. Sorry, you guys, technical
That's okay.
difficulties.
I'll tell you what, Youssra, why don't
I'm
you
gonna send it to you.
share that and we will take some questions because we have a few
Yeah.
questions in the chat box.
All right, so Bruce, maybe this one's for you, a general question just about proms, advance notification or knowledge of what proms are kind of going to be asked for. Let's start with that one.
Okay, so over the last couple of years, the ABOS has contacted your patients and given them a link to the Promise survey, and they could either fill it out or opt out, but that would be part of your case collection. I don't know that they're not still doing it because you haven't been contacted, but that has been the case over the last few years. So while it's not much you can control, it's an important way that they assess how you assess your practice. And from what I know, they're going to include that. At least I haven't been notified that they're dropping that.
All right. How are you doing, Youssra?
Let me try again. And in the meantime, I am just going to send it to you, Bruce, because I'm not, let me try once more because I feel like it worked. I thought it worked when we were, let me try one again. Anything or no, just my background?
We just see your background.
All right, let me, I'll keep talking and I'm just going to email it to you, Bruce,
Okay.
if that's okay.
Sure.
Yeah, 1 second. So, sorry, you guys. Oh, how annoying.
Bruce, in the meantime, let's do one more question. So a common question, just wondering, anything that should be read or prepared for in advance until the 12 cases are picked out?
I think that any background that you would have on your particular cases, if you do a predominant sports practice or hand practice or joint practice, you should be aware of the recent common literature. You know, I do joints, so it would be good for me to be up on the things that are popping up in the joint literature. Opioid usage, robotics, spine, spinopelvic relationship, those things that are common and have been really kind of popping up at all the conferences in the journals recently. I can't really speak to the other subspecialties. I'm not real facile with, but the other guys would. But that's what I would do. When they finally select your cases, it is very important that you have literature to back up your decision making. Even if it's appropriate decision making, they may ask you questions about why you did it this way. What is the best way to treat whatever DVT? How do the medicines work that you're currently giving? What are your other surgical options or non-surgical options? So I do think it's really important when your cases are selected that you have literature background.
I'll just add one thing. Don't get bogged down by the literature, but know at least 1 to 2 articles on the topic that you're presenting, so that if they do ask you if you have evidence to back it up, you do have something to back it up. And certainly if in your presentation you happen to say, the literature suggests, or even in your clinic notes, I don't know how people document their clinic notes, but some actually put in their clinic, make sure that you know the literature that you're referring to for that specific thing, whatever that case may be, because they will 100% call you on.
I agree with you, Mike. I think that if you have anything like that, anything you present to them, they will glom onto and ask you questions about. And the worst thing to do is to be spouting an article to the actual author. So if you happen to know a paper that was written by somebody that you're presenting to, if you're going to present that, you better know every in and out of that paper. So it's important to know the concepts, like Mike said. You don't really have to get bogged down to it. But if you start saying in a paper by Lombardi and you are being interviewed by Dr. Lombardi, you better know that paper.
Bruce, you cut out there for a bit. I'm not if you cut out for everyone or just me, but
sorry about that.
All right. So
Anything, anyone?
Yeah,
I saw your screen.
Now,
Let's see here.
Is it coming through?
Yeah, try advancing. Yeah, there you go. It's working.
All right. Okay. Now we'll just have to do it at double speed. So as I said, no longer virtual. We'll go through some of the things that are important. Attention to detail. Are we okay to move on to me? I just cut you guys off, so I'm sorry. Attention to detail, and I think case summaries are the way to sort of organize yourself, which are basically these. As I was starting to say, this is the rubric that you're scored by. You have access to all of this on your portal, and and it's actually important to go through it so that you don't just think it's like a walk in and they're going to get a feel for how prepared or not prepared you are. Like, there's an entire system to doing it. Everything that's in this scoring rubric is captured in your case summary. So even if somebody only has time to say, how succinctly do they present their differential diagnosis? Are they actually thinking about an appropriate differential diagnosis? And what is the primary surgical indication? Then it becomes very clear here. And I would venture to say it also allows you to prepare yourself to make sure that you're not missing anything that's important to include. The only thing really you can do moving forward are clearly your preparation for expecting what you might be asked, but really is your organization and preparation. This is an administrative job at this point. It's no longer a surgical job. It's literally thinking about how much time do you need in order to provide a clear presentation of the story, the indications, the decision algorithm, your post-op care, the management of your complications, and the ability to speak through your portal. It needs to read in a way that if no one ever met you and all they had to do was have an opportunity to read through what you uploaded, they can read it in a way that flows and that is smooth and that is dated properly and that doesn't require a whole lot of back and forth and doesn't feel like sort of a chaotic, charged environment. So what are the components? One is case summary, as we talk about, and then the detail there should include your thought processes, your knowledge base. It's sort of the difference between a medical student giving a presentation about a clinic patient versus an intern giving a presentation about a clinic patient versus a chief resident. The relative and important pertinence and impertinence are going to be very different based on the level of knowledge that those three different groups have. And this is basically looking at, have you been able to simmer down the parts that are appropriate and relevant to the story that you need to be able to tell. So write it as you would a succinct oral presentation. Document upload is super important. It's going to require you organizing all of the information in a way that allows you to be able to say, like, box checked. I have actually uploaded all of the pre-op x-rays that I think are relevant, the intra-op films that I think are important, and then the post-op x-rays that are going to be able to tell my story. If you have a beautiful intra-op fixation and then they come back at 2 weeks and the whole thing falls apart and you're like, I swear it looked perfect when I left the OR, but then you haven't actually uploaded your intraoperative films, it's hard for anyone to be able to follow your story. And you would be surprised as to how easy it is to not realize that you missed something unless you actually have a system in place. So the way that I did it is I literally had like a folder for each single patient. Within that folder had subfolders of pre-op notes, clinic notes, consents, op report, post-op notes, x-rays, etc. This is what it looks like ultimately, and you, I think, already have access to this. So this is just one thing, right? So this is just the pre-op documents for operation one of this case. So you'll have office notes and H&P. The way that you label these matters because it then uploads them in a way that allows them to follow each other. There's a very clear rubric in your giant thing that you have to go through that gives you 1,000 details as to how you should do this. It's actually important to pay attention to that. There's a clear rubric as to how you label these, and it's important to be able to make sure that they're labeled properly before you actually upload them. Otherwise, you have to keep editing them and then you'll lose track of it and it'll drive you crazy and waste your time. So all of that is sort of what, in terms of what you can start doing now, it's sort of reviewing that stuff and deciding how you're going to create your labeling systems for every single case. Not that you can actually do it because you don't have dates, et cetera. But becoming familiar with that makes a difference and helps. I mentioned that. And then image upload. Mike started to mention this where he's like, if you have an MRI, you're not going to necessarily just put every single cut of the MRI. A, you don't have enough space to do that. B, you can't actually put in a video. So you have to splice these panels that tell the story of what you determined to be the injury or what you looked at in your post, like if you did a scaphoid non-union and you're looking at your CT at 3 months to make sure that it healed, like what are the cuts that you're actually looking at? Did you actually get a navicular CT, a scaphoid CT as opposed to a regular CT? And then if so, you're only putting in the panels that are pertinent. You're not wasting their time with anything else because they want to know that you actually know what to look at. And it also helps to tell your story. It takes a long time to create those. So don't leave it to the last minute. Otherwise you'll end up having to be sloppy because you don't have enough time. There's something called a hospital statement. These are the things that for me at the last minute, I was like, what? I have to do what? And who do I talk to? And who even gives me this? It's more relevant for those that are using a mini C or even a big C that can't be de-identified. As you know, everything either has to be de-identified or you have to have a consent that says that patients don't care that their name is actually on every single document that you're uploading. If it has to be de-identified, a mini C, for instance, unless the nurse puts in the MRN for every single image, every single x-ray that you have, or you put it in yourself, you often can't have it appropriately identified, which means that once you remove the name and date of birth, you now don't have an identifier. They do not want you to just slap one on there because you can technically make it up. So then you have to figure out who the right person in the hospital is to say, I actually agree that this is the image that goes with this case, and I'm going to sign off to this statement. Those are all things that take time and require planning, which means that you have to know for your cases, which cases actually require that. What would I have done differently? I feel like I'm rushing since I made you guys wait. Redacting documents and creating advanced imaging panels takes a long time. So I actually would have done a lot more to try to set aside time to do that in a way that didn't feel hurried at the end. It eventually got done, but I actually ended up extending my deadline because I had CTs and MRIs, et cetera, to be able to do it properly. Create folders for each patient to stay organized and actually use them. Don't just put them there for the sake of feeling like you're being organized. You actually have to refer to them and use them. As Mike was saying, super important to discuss your cases before you actually present. I think it's equally important to discuss your cases before you actually finalize your uploading of all of your documents. That could be only going through the case summaries, because even in discussing the case summaries, if something doesn't make sense, whoever you're talking to will say, it seems like that detail is missing, or why did you do this, or why didn't you do this, or what information do you have to be able to support that? So if you have access to someone that you can do that with before you upload, I think it actually keeps you more organized for the uploading process. We're all very busy and nobody wants to take time off, and you want to do this in your weekend time and when you're done with clinic and when you're in between cases. And sometimes that works, but I actually think building in admin time in the weeks prior to the deadline to avoid any last minute panic is important. And it requires building it in and actually having people respect it, as opposed to, I have 2 hours every Thursday afternoon from 1 till 4 o'clock for admin time. And they're like, we have patients that need to be put into clinic. Can you please see them? The answer is no, because you actually need to protect that admin time to get it done. And then I would venture to go as far to say, take time off like the 1-2 days before the upload date, deadline, to confirm that everything flows properly, that you feel good about the completion, that if you submitted it, you don't even have to think about it until the day of. And then when you're reviewing it to actually present during the oral boards, then you're prepared as well, and you can avoid last minute panic. And then use the late deadline if needed. There are no penalties. Nobody looks at this and they're like, ooh, Marjoua ended up needing to push this back a week. Clearly she's not prepared. They don't even know. So if you need the extra time, it costs you some money, but it's worth the money. Don't be afraid to use it for the sake of just submitting what you deem to be on time. So you could see here that the most common theme is time. Time is the most valuable commodity you have. So create it just to get this done properly. This is literally a secretarial job at this point. So just be a good secretary to yourself. And then where do you begin? Everybody feels overwhelmed if they tell you, oh, you're going to be totally fine. It's not as bad as you think, etc. They all felt exactly the same way as you do now. So it's okay. It's normal. Take a deep breath. You're going to get through it. Download Adobe Pro. If you don't have patient consents and you can't skip the redacting, you do need Adobe Pro to be able to do it properly. I don't know that you can actually mark it out with a marker. I don't even know if it's allowed, but do it. It's worth the $15 a month, or it's even a free trial for the first month. Worth it to do it. Review the labeling system for your notes and your images. Look at your schedule and create protected time. Create a checklist to make sure that you're actually uploading properly. I literally had for every single patient like a checkbox of pre-op notes, op notes, consents, etc. And as you upload it, just check it off. Then you're keeping yourself kind of rigidly honest. As was mentioned on multiple occasions, ask a colleague to review your cases with, and then get to work. The good news, however, is that you've actually kind of done the hard work. You've done the surgery, and the surgery is the important part. Now you just have to tell your story. And how amazing is it that you get to tell your own story on your own terms? And it's all temporary. It sucks for the few months that you have to be able to get it done. And then once it's done, you can look behind. When Dr. Gomberg, who I'm not going to date by age, did have to do this, you actually had to have giant folders that you had to print out and take in and carry an extra suitcase for to be able to take to the exam. Now you can change this 1,000 times until the very last minute, until you're happy and comfortable. So that's an upside. I actually think this is the most important exam we take. Every other exam that we've taken up until now, if you're a great test taker, you can kill it. If you're not, then you don't. This is one where you don't necessarily have to be a great test taker. And if you are a great test taker, it doesn't help you or not. It gives you the opportunity to delve into your own work and critique your own work in a way that you would never actually choose. So use it as an opportunity to sort of set kind of the standard for how you want to do it moving forward in your career and in your practice. This is the reason that it was created. And then you have another day to celebrate once you actually submit everything before you even take the test. So you have something to look forward to. All right, that was all that I had to say. I hope I didn't talk too fast. Thank you for dealing with my technical difficulties, and we'll answer any questions that you guys might have.
I think that was a great summary. And in fact, you finished early. We've got 5 extra minutes for questions. So amazing. All right, so we've got a few more questions. One is about mini CRM images that are not transferred to PACS, but they're saved on the mini CRM. Questions about whether scanning that image or a photograph of the mini CRM image is going to be accepted.
Yes, it is, but that's the one that you have to get the hospital statement upload, because unless that mini C-arm has the patient's MRN without their name and any other identifier, it is not legitimate. It could literally mean that you took a mini C-arm image off Google and put it up, for all they know. Not that anyone would do that. But the goal of making sure that you have the hospital statement uploaded is to make sure that someone in your hospital or in your practice looked at it, agrees with the fact that it was the image that you took, signs off on it for that particular case.
All right, and we have actually a follow-up question to that form. I think they're looking for just a little more clarity on who you're going to go to get the statement signed off on.
I have no idea. Every single hospital is different,
Right.
which is why I say the one thing I would have done differently is not waited until a week before to do it. So that's something to find out now. Just say, hey, for the boards, we have to have these images submitted and I need somebody to sign off on these. Who's the right person to ask? Is it like somebody that is the director, the medical director? Is it the chief of the department? Is it somebody that's just in radiology and an admin person? I don't actually know. And I would bet that there's somebody in your practice or in your hospital that took the boards recently enough, i.e. in the past 10 years, that may have had to do the same thing and can speak to it. And it's usually going to be mostly for hand and foot and ankle, because we're really the only ones that end up using the mini C more than anything.
All right, we have, what else do we have here? A question about the breakdown of how much theory literature is going to be asked versus specific questions about the actual surgery.
I'll answer and then I'll pass it off. I think that if you're in the room and the discussion has gone towards like, what's a Martin Gruber anastomosis and what does that look like on EMG, you're fine. Because then that means that the review of your case, your presentation of the case, the things that need to be checked off, as in, you know what you're talking about, you're a safe surgeon, et cetera, have kind of been checked off. And now they just want to assess your knowledge base and your ability to think on your feet. So from my perspective, unless the questions are specifically related to what is your indication for doing an endoscopic versus open carpal tunnel release, like that you should know. What is the anatomy of the median nerve from its exit point, the brachial plexus, until its sort of insertion and distal innervation, that you should know. But in terms of theory, esoterics, et cetera, I think that usually ends up happening when there's already a pretty good idea of where you are in terms of scoring, et cetera.
So I'll add to this, and I think that in the arthroplasty world, there's a fair amount of theory that you need to know. You need to know a little bit about metallurgy. You need to know a little bit about biomechanics. You need to know a little bit about basic internal medicine. You know, they're going to ask you about DVT prophylaxis and what you used and why you used it and how each form of prophylaxis works. They're going to ask you about what antibiotics you used and how they work. They're not going to harp on it, but they want to know that you're safe and ethical. And part of that is having a reasonable fund of knowledge.
All right, we have another one. Bruce, maybe you can take this one. Having a combination of cases, so a large proportion of hip and knee arthroplasty, a smaller proportion of spine and trauma. Is there any way to estimate who might be, who you're going to be assigned to as your examiners?
I think I'm going to defer to Mike and Youssra, who might know that more. I mean, as far as I know, you had to designate how you're going in, general, sports, hand, but I don't know what they're doing over the last few years about this.
Yeah, for me, you had to designate. And somebody asked a question, you know, did you know who was going to be testing you? You don't know until test day.
You know, you find out test day, and if there's a conflict, they want you to bring it up. If you know the person or
Correct, yeah.
one of your professors, so they can shuffle people around. So you won't be examined by somebody who supposedly has knowledge of you or your surgery or was your professor.
All right, we've got another question here just about the pass-through based on simply what has been submitted. Wondering whether pass-through is still going to happen this year or if everyone's going to be examined.
I think everyone's going to be examined. I think the pass-through was when it was a virtual option, and it was sort of the first, it was when everything was still happening, and it was a first attempt at determining if that would be a feasible option. I will say, and I think it's something that they have looked at for a while, and Bruce, correct me if I'm wrong, where there was always kind of a parallel assessment of kind of people being examined live in addition to having their packets examined to see if the virtual aspect would work. But I think that they're going back to everybody submits kind of the traditional way. Everybody submits, and there's no pre-review of anything in a way that determines whether you have to sit or not. Everyone sits.
Correct.
All right, another question here just about whether the proms, how they count towards the overall score.
They don't, from what I know. I literally just got an email. So I was 2020. So I literally just got an email like 2 months ago, giving me all of the results of my proms, mostly as like, we thought you should know that this is what your patients thought about you, et cetera, et cetera. But I don't think it's actually weighed in any way. I think they've been collecting it to determine if it could be included in some way, but I don't know that it actually has. It's not in the scoring rubric.
I agree with you, Youssra. I think they're trying, but haven't figured out a way how to use it yet.
All right, Youssra, this one's going to go to you. Just we've got 3 more questions, and they're all about how to deal with an image that doesn't have the patient data on it. So clarifying what needs to be on the image and what needs to be redacted, I think is going to be helpful here.
Yeah, so similar to everything that has to be on your documents, the only thing that can be on the document is the medical record number or the medical identifier or whatever it is. You can't have the patient's name, you can't have their age, you can't have their anything else. So that means that the image can only have the patient's MRN as well. So on a CT scan, that's easy because every CT scan typically is going to have an MRN and a et cetera, et cetera. MRI is going to be the same way. An X-ray will as well if it's like a true flat panel outpatient clinic X-ray. A mini C-arm image or a big C-arm image that is not identified in a way that has the patient identifier without any other identifiers cannot be used. You'd have to redact the whole thing and block it out. If that's the case, you cannot just put in a box that then says patient MRN is X, Y, and Z and like slap it on there. If you don't have the MRN on there, or once you remove all the other identifying information, there's nothing else to identify the patient with, that is the reason to get the hospital upload statement to confirm that someone other than you is looking at the images and saying, yes, I agree, patient X is indeed patient X, as Dr. Jones has indicated.
Sounds good. All right. Well, I think we have gotten through all of our questions. We might give it a minute for any last minute questions, and then we'll be tying things up here. Oh, here we go. One more question about how the proms are collected. Do they need to collect them themselves? And I think we've already answered that it's the ABOS that's going to be collecting them directly.
No, you have to. So you have to provide patient emails.
Right.
Every single case that you uploaded, you probably did this already though. Every single case that you uploaded required a patient email that you included as part of your upload. So they would then reach out to them once that email is in. You don't have to do anything else.
All right. I think one last question here, just a question, Bruce, about whether we might be supplying this as a recording for others to check in on.
We might be. I'm at this point we haven't decided, but stay tuned. If we do offer it, I'm sure we'll post it on social media, and hopefully we can even have more webinars like this. And I also want you to know that we're all faculty at the Maine Orthopaedic Review, and if you have any questions, you can email us. My email is director@maineorthopedic.com, and I'm happy to share with you my knowledge or whatever answers I can give you to your questions. And I hope that you all do well. I wish you luck. And if you really want the best absolute feedback, come to the Maine Orthopaedic Review. We will review all of your cases, all selected cases. We'll get through just like this, as much time as you need, with people like this and even more. But none as handsome as Mike O'Malley. But we're happy to do that. We're happy to help you get through and present your cases in the best possible light, making the most cogent arguments and learning the pitfalls and what the examiners are going to ask. We've been doing it a long time, all of us, and we're happy to help you. Any other questions? I haven't really been checking the boxes. Emily, have you?
There's just one last one about the technicality of hospital privileges as of November 1st, and a question about the subspecialties that are mostly outpatient based, like sports and hand. Are surgery center privileges by November 1st enough?
I would venture to say yes. I think it's such that you have been able to actually start doing surgery.
Yeah, that you're in practice.
Yeah, so I don't think it has to be hospitals.
Yeah,
I agree.
But I will say the only thing I'd add there is everybody has an ABOS person based on your last name. Kim Grover was mine. You can reach out to them and send an email about any questions that come up like this, so that if it's something where you're like, I'm not really sure, should I even have been collecting, etc., it's not something that you want to kind of guess. So that's stuff that you can just send an email to whoever your assigned person is based on your last name, etc., to be able to answer those questions.
I agree. They're very prompt about doing that, and anything you ask will be answered right away by appropriate people. So I would like to just extend my thanks once again to Mike and Emily and Youssra for joining me tonight, and to everybody out there. I hope that everything goes well. Like I said, if you have any questions, contact us, and we're very happy to help you out and committed to help everybody get through this. We know it's a stressful time, and you'll all do fine. Thank you, everybody.
Thank you. Good luck,
Thanks.
everyone.
Guys.
Good
Bye,
night and
everybody.
good luck.